Hi, my name is Helen Herrera, and today I'm going to talk about a novel familial cardiac arrhythmia syndrome with widespread ST segment depression. So first, I'm a med student at Universidad Católica Santiago de Guayaquil, and here are my Facebook, Twitter, YouTube, and Instagram accounts so you can follow me and watch the other videos I have uploaded. First, the definition. The novel familial cardiac arrhythmia syndrome with widespread ST segment depression was described by H. Bongard in 2018. It's characterized by widespread concave outward ST segment depression. This syndrome is associated with atrial fibrillation and sudden cardiac death due to ventricular tachycardia and ventricular fibrillation. Autosomal dominant pattern is identified in this syndrome.
A novel familial cardiac arrhythmia syndrome with widespread ST segment depression is described in this video. Have fun and enjoy. In November 2018, Henning Bongard and co-authors described the new electrocardiographic pattern associated with the sudden cardiac death. They found this pattern in 5 unrelated families from 3 different countries. ECG reveals a deep and persistent concave upward ST segment depression in the leads 1, 2, AVL, AV foot, V2 to V6. Often ST segment elevation is registered in the leads V1 and AVR. The ST segment in precordial leads may be notched. The notch is the most prominent in the leads V3 and V4. The ECG changes are permanent and are worsened upon exercise. This ECG pattern was being registered even in a child of 6 years of age. The atrial fibrillation develops frequently in such patients, and in few years ventricular tachycardia or ventricular fibrillation develop, leading to sudden cardiac death. But in young people, usually ventricular tachycardia or ventricular fibrillation occur without the previous atrial fibrillation. Coronary angiography reveals no coronary artery disease. Systolic ventricular function usually is normal, but sometimes the mild ventricular dysfunction may be found. Genetic tests include genes associated with cardiovascular diseases are negative. Studying the genealogy of affected patients, an autosomal dominant pattern was identified. Often, relatives have similar ECG changes. Often, affected people are completely asymptomatic, but symptoms appear when the atrial fibrillation, ventricular tachycardia, or ventricular fibrillation develop. Non-sustained ventricular tachycardia may result in a syncopal episode. The ventricular tachycardia often transforms into the ventricular fibrillation, leading to sudden cardiac death. This syndrome is not well understood. Probably, channelopathy plays a key role in the pathogenesis of this syndrome, but the gene associated with this disease is still not detected. It's unknown whether arrhythmic drugs can prevent the sudden cardiac death. An implantable cardioverted defibrillator is recommended for the patients that survived ventricular tachycardia or ventricular fibrillation. Thanks for watching this video. Please
Applications in medicine. DTU supercomputer, computer room applications in medicine. How this app helps in medicine. Scientists have used one of the largest supercomputers in the world, computer room, which is in the DTU. Its function is to map the genes of patient, which can be determined if the person is predisposed to develop newly discovered heart disease. We will know the predisposition to the disease even before the patient goes to the doctor with any symptom. In an ideal situation, this knowledge will not only allow early diagnosis of the disease, but also the development of new drugs or therapeutic strategies. Pros and cons. The advantage of this is a systemic discovery of this new genetic heart disease recently discovered by a very unusual pattern on the electrocardiogram (ECG) of a man who survived cardiac arrest. use of bioinformatics for the study of genetic mapping and the discovery of new mutations related to this new cardiac condition. Although the reference genome describes the damaged genetic material, the knowledge resulting from the project is of international relevance, since it can promote the development of personalized medicine.
Finding the genes that cause heart disease. Characteristics are passed on from one generation to the next in our genes. Genes are made of DNA. The DNA code is made of 4 building blocks, known as bases. These are adenine, thymine, cytosine, and guanine, or A, T, C, and G. Bases join together in pairs, known as base pairs. A always links to T and C to G. Our full DNA code has 3 billion base pairs. A mutation or fault is a change in your DNA that results in an abnormal gene. Some conditions are caused by a single faulty gene. For example, Marfan syndrome, which can cause aorta and heart problems. Most of these conditions are rare, but when you add them all up, they affect many people. An estimated 620,000 people in the UK carry an abnormal gene that can cause heart disease. The BHF is funding Dr. Sanjay Sinha and his team to find out how the Marfan syndrome gene affects cells. They do this by comparing cells from people who do and don't have Marfan syndrome. Their work will help us understand how this rare condition affects people and could lead to new treatments. There are also more common genetic differences. For example, you might have an A in your DNA, where someone else has a G. These are called polymorphisms. Some of them are responsible for everyday differences between people, such as blood group or hair colour. Other polymorphisms are linked to disease. Individually, they don't cause a disease like a mutation can, but they can increase your risk. Another team of BHF researchers, led by Professor Sir Nilesh Samani, found one of the first common polymorphisms that can increase your risk of heart attack. We now know there are more than 90 polymorphisms that increase your risk of heart attack. The more you carry, the higher your risk. You inherit polymorphisms from your parents in the same way you inherit faulty genes. We haven't found all the genes linked to heart disease. We need more research to find the rest and work out how they affect our risk of heart disease. This will help us to better identify who is at risk, reduce the risk, and develop new treatments. Our researchers are working hard to make those discoveries and help save lives.
Disadvantage. It is common for family members with abnormal ECG to experience severe heart rhythm disorders. Some develop a reduced pumping functions of the heart, and in some cases, the disease has caused sudden death. The disease can easily be confused with other conditions. This means that researchers are not sure how many people suffer from the disease and how many people have been misdiagnosed.
First described in 1992 by the Brugada brothers, Brugada syndrome is a genetic disorder that can disrupt the normal rhythm of the heart. Those affected by this condition have an increased risk of sudden cardiac death. It is a much underdiagnosed condition, as most of the people who have Brugada syndrome are unaware of it due to lack of any symptoms. The normal heart has 4 chambers. The upper chambers are known as the atria, and the 2 lower chambers are known as the ventricles. Electrical impulses cause the heart to beat. The conduction of electric signals is made possible by special molecules called ion channels, which govern the movement of the positively and negatively charged particles. In Brugada syndrome, these ion channels do not function properly. The electrical impulses between the ventricles become uncoordinated. This condition is also called as ventricular fibrillation, which results in decreased blood flow to the brain and heart and can be life-threatening. Brugada syndrome can present with dizziness, fainting, and palpitations. It may lead to severe breathlessness and extremely fast and chaotic heartbeat. Sudden cardiac arrest is one of the dreaded complications of Brugada syndrome, and if not treated immediately, this sudden loss of heart function, which often occurs while sleeping, is fatal. If other family members have had Brugada syndrome, the risk builds up hugely. Although women and men are equally affected, men are more likely to develop symptoms than women. This gender distinction is probably related to the distribution of ion channels in the heart. In the presence of Brugada syndrome, fever is one of the triggering factors and can stimulate a fainting attack or sudden cardiac arrest, especially in children. Diagnosis of Brugada syndrome requires careful evaluation of the heart and the standard 12-lead ECG. The great diagnostic dilemma is in the asymptomatic patient who does not have a family history of Brugada syndrome, but instead has a suspicious-looking ECG. In such patient, Brugada phenocopies are eliminated. Brugada phenocopies are clinical entities that have ECG patterns identical to true congenital Brugada syndrome, but are elicited by various clinical conditions such as metabolic derangements, mechanical mediastinal compression, myocardial ischemia, and pulmonary embolism. Provocation ECG test is done with drugs, and once that is confirmed, the risk is stratified. If the ECG confirm abnormal pattern, electrophysiologic test is suggested, in which a catheter is threaded through a vein in the groin to the heart. Electrodes are then passed through the catheter to map out any irregular heartbeats. The first line of treatment, suitable for all the patients regardless of the risk of arrhythmias, is lifestyle advice. An implantable medical device, called an ICD, or implantable cardioverter defibrillator, is the main treatment. This device continuously monitors the rhythm of the heart and also delivers calculated electrical shocks to the heart to control abnormal heartbeats. Long-term follow-up of Brugada syndrome patients confirms the clinical efficacy of ICD devices. Certain drugs that counteract the iconic current imbalance in Brugada syndrome could be used to treat it. These drugs prevent the heart from going into its potentially dangerous rhythm. For more information about list of expert doctors, hospitals, and ongoing clinical trials, please visit www.expertdocs.com.
Issue apply in Ecuador. Cardiovascular diseases are the first cause of death in the country. The cardiac arrhythmics caused around 178 deaths only in 2016. And here is a video of a normal patient with cardiac arrhythmia.
I grew up doing a lot of backpacking and hiking with my dad growing up, and then he and I started climbing mountains together in my early 20s. My dad passed away a couple of years ago, and shortly after I started having a lot of PVCs, like a strange heart arrhythmia, which was initially diagnosed as like a stress-related condition due to all the grief and trauma of the experience I had been through. I ended up feeling really just terrible most of the time, very fatigued and lightheaded and dizzy. But it continued to increase and get worse, so then I was referred to Dr. Dan DeMoody. And at that point, he did not think they were related to stress at all. It was just an electrical misfiring with the cells in my heart. So early April, I had the heart ablation surgery. And then 4 weeks later, I did my trail half marathon. And about 2 weeks later, I climbed Mount St. Helens. About 3 weeks after that, I climbed Mount Baker. And about 3 weeks after that, I climbed Mount Rainier. It was wonderful to be able to run and not have my heart to be doing anything strange and to feel really good. It was probably the best I'd felt on a run in a long time.
Conclusion. Bonger et al. Have presumably identified a novel familial cardiac syndrome. Diagnosis of this syndrome is based on ECG, family history, and clinical presentation. Given the prevalence of atrial and ventricular arrhythmias and sudden cardiac arrest, this syndrome appears to be very serious. That's why we need to know the causes and the physiopathology of cardiac arrest. And finally, now watch this video.
Cardiac arrhythmias can be classified by site of origin. Sinus rhythms originate from the sinoatrial node or SA node. Atrial rhythms originate from the atria. Ventricular rhythms originate from the ventricles. Sinus rhythm is the normal rhythm of the heart set by its natural pacemaker in the SA node. In a healthy heart, the SA node fires 60 to 100 times per minute, resulting in the normal heart rate of 60 to 100 beats per minute. The most common variations of sinus rhythm include sinus bradycardia, when the SA node fires less than 60 times per minute, resulting in a slower heart rate of less than 60 beats per minute, and sinus tachycardia, when the SA node fires more than 100 times per minute, generating a faster heart rate of greater than 100 beats per minute. Sinus bradycardia and sinus tachycardia may be normal or clinical depending on the underlying cause. For example, sinus bradycardia is considered normal during sleep, and sinus tachycardia may be normal during physical exercises. Cardiac arrhythmias that originate from other parts of the atria are always clinical. The most common include atrial flutter, atrial fibrillation, and AV nodal reentrant tachycardia. These are forms of supraventricular tachycardia, or SVT. Atrial flutter, or A flutter, is caused by an electrical impulse that travels around in a localized self-perpetuating loop, most commonly located in the right atrium. This is called a reentrant pathway. For each cycle around the loop, there is one contraction of the atria. The atrial rate is regular and rapid, between 250 and 400 beats per minute. Ventricular rate, or heart rate, however, is slower, thanks to the refractory properties of the AV node. The AV node blocks part of atrial impulses from reaching the ventricles. In this example, only 1 out of every 3 atrial impulses makes its way to the ventricles. The ventricular rate is therefore 3 times slower than the atrial rate. This is an example of a 3-to-1 heart block. Ventricular rate in A flutter is usually regular, but it can also be irregular. On an ECG, atrial flutter is characterized by absence of normal P wave. Instead, flutter waves, or F waves, are present in sawtooth patterns. Atrial fibrillation is caused by multiple electrical impulses that are initiated randomly from many ectopic sites in and around the atria, commonly near the roots of pulmonary veins. These unsynchronized, chaotic electrical signals cause the atria to quiver or fibrillate rather than contract. The atrial rate during atrial fibrillation can be extremely high, but most of the electrical impulses do not pass through the AV node to the ventricles, again thanks to the refractory properties of the cells of the AV node. Those that do come through are irregular. Ventricular rate, or heart rate, is therefore irregular and can range from slow, less than 60, to rapid, more than 100 beats per minute. On an ECG, atrial fibrillation is characterized by absence of P waves and irregular narrow QRS complexes. The baseline may appear undulating or totally flat depending on the number of ectopic sites in the atria. In general, larger number of ectopic sites results in flatter baseline. AV nodal reentrant tachycardia, or AVNRT, is caused by a small reentrant pathway that involves directly the AV node. Every time the impulse passes through the AV node, it is transmitted down to the ventricles. The atrial rate and ventricular rate are therefore identical. Heart rate is regular and fast, ranging from 150 to 250 beats per minute. Ventricular rhythms are the most dangerous. In fact, they are called lethal rhythms. Ventricular tachycardia, or VTach, is most commonly caused by a single strong firing site or circuit in one of the ventricles. It usually occurs in people with structural heart problems such as scarring from a previous heart attack or abnormalities in heart muscles. Impulses starting in the ventricles produce ventricular premature beats that are regular and fast, ranging from 100 to 250 beats per minute. On an ECG, VTach is characterized by wide and bizarre-looking QRS complexes. P wave is absent. VTach may occur in short episodes of less than 30 seconds and cause no or few symptoms. Sustained VTach lasting for more than 30 seconds requires immediate treatment to prevent cardiac arrest. Ventricular tachycardia may also progress into ventricular fibrillation. Ventricular fibrillation, or VFib, is caused by multiple weak ectopic sites in the ventricles. These unsynchronized, chaotic electrical signals cause the ventricles to quiver or fibrillate rather than contract. The heart pumps little or no blood. VFib can quickly lead to cardiac arrest. VFib ECG is characterized by irregular random waveforms of varying amplitude with no identifiable P wave, QRS complex, or T wave. Amplitude decreases with time from initial course VFib to fine VFib and ultimately to flatline.
Thanks for paying attention.